open doors to some new collaboration. So once again, I wish you welcome, and I wish you some pleasant time and fruitful time together with us. With me here today are also our guests, Mr. Fatih Ben Hamadou. Is it correct? Yes, yes. And it is a business development manager from Synlab for 30 parties, and he will explain his function in his work in Synlab, but also he would introduce our special guest, Professor Dr. Matthias, who in Synlab made this test that we are now speaking. Please, Fatih.
Dame i dobre dan. So you believe maybe I will continue speaking is very Serbian, but it's not the case. I will speak in English. So you are welcome. You are welcome joining this session. We are very happy together with Aqualab to hold this session for Mikrobiom. It is the second or the third part we had, the third time we had such a session, and I see some of the colleagues or doctor are also here. It is a great pleasure to have our Professor Dr. Willmann here to proceed with the lecture for Mikrobiom. All about is customer centricity. So with the collaboration of Aqualab since many years, we see that there is a success behind, and it is because of this sense, having the customer as the middle of all what we are doing. So happy to have you here, and I hope you have a nice session where we continue discussing and working with you together. Matthias, you have the word.
Thank you very much. Thank you, both of you, for the kind introduction. And thanks a lot to everybody from Aqualab for inviting me, giving me the opportunity to come to Belgrade to talk to you, to discuss to you. I'm always very happy to be back in Belgrade. Some of you are already told. My wife comes from Belgrade, so I'm regularly here once, twice a year visiting the family. So I'm really, really glad to be back. And I would just like start a little introduction about me. So I'm a medical doctor. I'm a specialist for microbiology. I worked for about 10 years at the University of Tübingen as a professor, and so my research field was mostly microbiome studies and the relationship between gut microbiome and dementia, primarily Alzheimer dementia. And later on I became medical director in a big laboratory in Germany, which was run by Eurofins. And 2 years ago, I changed, so I became medical director of Labor Dr. Bayer, which is a specialized lab within Synlab, and this lab actually provides very, very specialized tests. And one of the tests, also what we are talking about today, is the microbiome, the gut microbiome test. And as you have seen, I have prepared all the slides in Serbian language. I hope this is helpful for you. So I have translated, or I let it translated by artificial intelligence. So my wife has checked it. She has double checked it, so that I haven't totally messed it up. But if you realize that I talk something completely different to what is on the slide, you can of course always stop me and ask me questions. And I would say let's start with this very exciting topic that follows me my whole professional life, microbiome. And today we will mostly in this first part talk about what is actually the function of the microbiome, how is it connected to disease, and how can we use it as or the test of the microbiome, how can we use it in a clinical sense, what benefits, what information can we gain from it, and how can our patients basically benefit from this information. So And with that, this is the content of my talk. So we'll first talk about the microbiome itself. So what is it? Also about how can we measure it. I think this is something that is very important. We will then talk about the relationship between the gut microbiome and the irritable bowel syndrome, IBS, which is actually a good example for a local affection of the gut microbiome. We will then also talk about another disease, about the relationship between the gut microbiome and endometriosis, which is a very nice example for the systemic influence and impact that the gut microbiome can have on diseases, which is actually also transferable to other diseases, which are inflammation-based. And I would also like to present you some practical cases, which I hope make things more plastic and more understandable how we can basically use this. So a little introduction about the gut microbiome. It's always thought that this is a very new thing and maybe something that came up in the last 10, 15 years, kind of hype now. But basically it isn't. It has been discovered quite a while ago. And the discoverer was Antoni van Leeuwenhoek. He was a teacher actually from Netherlands. He was he had many professions, philosopher, he was a physician and also physicist. And in his leisure time, he built lenses. And with the lenses, he built microscopes. And one day, he put his own saliva under the microscope and just looked at it. And what he saw, he just wrote it down. He wrote a letter to the Royal Society of Physicians in London. And, well, so this is actually what he has written. He said that the people living in our United Netherlands are not as many as the animals that I carry in my own mouth today. And with that, basically, he is not only the discoverer of the gut microbiome, basically he's also the discoverer of microorganism itself. So it is quite an old thing. But it took a while until we really discovered the gut microbiome. And this is true. This is for technical reasons. This is something that happened in the last 10, 15 years. And what he actually described was the definition of the microbiome. You can say the microbiome is just the totality of all microorganisms in any living habitat. It can be soil, can be the ocean, and can be, of course, human body. We are most interested in the human body, and this is called the human microbiome. You could also a little bit differentiate between the term microbiota, which basically means the same. It's just a living organism in a habitat, while microbiome refers to the genes of these microorganisms. And since we are measuring the genes nowadays, the term microbiome became more popular than microbiota. Okay? So, and when we talk about the human microbiome, there are also so many different microbiomes. We have the microbiome of our skin, of our mouth, the oral microbiome, and of course also other microbiomes. And the most popular one, most famous one, is the gut microbiome. And the reason is because there are just basically most bacteria in there. It has the biggest impact on the one hand. On the other hand, it is quite easy to investigate because there are so many bacteria. And that's why most studies actually have been performed on the gut microbiome. So just a very short introduction. How do we do it actually, this test? So basically we have a stool sample, and based on that we extract DNA, RNA from it. So it's a molecular-based test. That's very important because otherwise we would not be able to describe the microbiome, actually any microbiome, comprehensively. The reason, therefore, is if we would use the traditional culture methods, like what Robert Koch, Pasteur have actually invented, we would not be able to see most of the bacteria. They simply do not grow. More than 95% of bacteria do not grow under standard culture conditions. So we would not be able to see them. And for that reason, we basically sequence them. We get their genes, the DNA, RNA, and what we then do is a kind of PCR. It is more than a PCR, it's called next generation sequencing. Some of you probably already heard of it, so these kind of devices. It is more complex than a PCR. In a PCR, I sequence like a single part of a DNA, for instance, from a pathogen, and then I know the pathogen is in the sample. But in this case, it's different. In this case, there is a parallel massive sequencing of all the DNA that is basically in the sample. And what we get is not like, a huge sequence of a genome. We don't get it. We only get like little pieces, which we call the reads. It's actually what you can see here. Little DNA sequences, 150 base pairs, 250 base pairs, something like this. Okay? Once we have that, we have a reference database with known sequences from microorganisms. And then we look whether this sequence matches to the reference sequence. Let's say this reference sequence is E. coli. Okay? And we know, okay, because all these reads, they matched against it, we know, okay, these sequences, they come from E. coli. And the only thing that we need to do now, we count them. And with that, we get the abundance, because the more E. coli in the sample, the more sequences are produced. And that's how we know what's actually in the pot and what are the relations, the quantitative relations of each species to each other. And this is basically done in a bioinformatical analysis. This is like a hardware center. It just should symbolize that we need some hardware power in order to do that, because it's big data analysis. And in the end, we have the information, how many species do we have of species A, B, C in that sample. Okay, that's what we have. And then another difficult part really starts, and this is actually the medical interpretation, the medical report that we then provide. We have to think about how can we interpret this information in a useful way for our patients. What does it mean, what we see? And it's just a first page, which provides some general information. I will come to that back later on. In the lower part, you would already get some pretty important information about this sample. Well, our test is also IVDR conform, so we have fulfilled all criteria of the attachment 1 of the IVDR. And with that, I just want shortly also introduce the gut microbiome to you. The average human has about 200 grams of stool in the colon. With that, there are 39 trillion bacteria in it. Interesting, we only have 30 trillion million cells in our body. So we actually consist of more bacteria than we have our own human cells. And it's not all, it's just bacteria, okay? We don't know really so much about viruses, fungi, single-cell organisms. They're also in there. So a lot. And also, we have their genes in there. We humans, we have something like 25,000 genes. But they have 100 times more genes. And that's also why it is called the second genome. And it's not only that there are some genes like swimming in a soup of the colon. No, it's not. We basically use these genes. And for that reason, the gut microbiome is nowadays, even under specialists, I have to say, recognized as an organ, because this organ is fulfilling a lot of functions for us. And we can differentiate between two major functions. One is a metabolic function. It produces metabolites like vitamins, it inactivates toxins. It's very important for actually our energy production. It's very, very important for fermentation, for instance, processes. And it's also very interesting, and I think this number is, I am still very impressed by this number. 50% of the metabolites in our blood, they come from the bacteria of the gut microbiome. And they go everywhere. They go in each organ. They go in our brain. And now I think you can imagine what kind of interaction that is between human and bacteria, and how basically the gut microbiome can influence health and also disease. It does also have immunological function. It stimulates immune cells, very important also for development of our immune system. And also, it's very important that we do not, or that we are protected from pathogenic bacteria. I also come back to that later. This is actually the only slide where I'm a bit more into physiology. But it is a very good example of what the gut microbiome is doing. You all know we give our patient antibiotics, and what can happen, of course, diarrhea. In the worst, or one of the worst cases, Clostridium difficile infection. Common thing in hospitals. And how does it happen, actually? It happens in that way. So we as humans, of course, we produce a primary bile acid. It's very important for our lipid resorption. And these primary bile acids, they actually promote the growth of Clostridium difficile. So the thing is, once we have a healthy gut flora, a healthy gut microbiome, they will actually metabolize a primary bile acid into secondary bile acid. And these secondary bile acids, they're different. We do not really use them in a very hard way anymore, but what they are doing, they protect us from Clostridium difficile. Okay? And now imagine what happens. So we administer antibiotics to the patient, we destroy basically the gut microbiome. So we have much, much more primary bile acids and almost no secondary bile acids. The point is nobody stops Clostridium difficile from proliferating and producing the toxins. And that's basically the way how there is this interaction between gut microbiome, antibiotics, and Clostridium difficile. So I think it's a very nice example. Of course, when we think that sometimes something is wrong with the gut microbiome, as we just have seen it, there is, of course, always a very important question: how can we somehow modify the gut microbiome? And this is a very interesting study, the Lifeline Deep Cohort Study, 2016, published in Science. A lot of people have participated in that study, and they have investigated what are the primary factors that would influence the gut microbiome. And not surprisingly, you see, mostly it's diet, food, right? Also smoking habits, medication, host factors, diseases. So there are some, but I guess the most important point is diet. What we eat is in the very end of what we get. Yeah. So what you can see here, it's like on the top here is how many carbohydrates do we eat. This very, very much influences our gut microbiome, because what we eat is actually also their food. Okay? When we eat differently, different bacteria come into our gut, right? Also, until how often do we drink coffee? How often soda, vegetables, red wine? Everything basically influences the gut microbiome. I mean, we could talk for hours, actually, what are the major factors. I think the factors that are also very important for us is medication that we provide to the patient. And I think for everybody it is quite clear, antibiotics, of course, yeah, they destroy the gut microbiome, they influence it. But there are many, many other drugs. And interestingly, when you look at this, again, this column, what you can see here, is a kind of quantification how much one of these factors influences the gut microbiome. Look at it. Not antibiotics are at the first place, as we might think. There are others on the first place. Things that are often also be given on a long term. Statins, for instance. Yeah? Also proton pump inhibitors, also quite long term sometimes. Yeah? Many also beta blockers, antidepressive medication, everything or any of these medication significantly impacts the gut microbiome. We have to keep that in mind for later, okay? It's very important. So now I would like to start with the first thing that I have mentioned, the important relationship between the gut microbiome and the irritable bowel syndrome. I've chosen this as an example because the irritable bowel syndrome is a very common problem. So I'm not so sure about the prevalence in Serbia. I haven't found something, but in Germany the reported prevalence, about 11%, more than 8 million people in Germany suffer from an irritable bowel syndrome. So you can imagine how often this is discussed in medical practice in Germany. Well, quite often, right? And well, principally, this is a clinically diagnosis. It is diagnosed according to the Rome 4 criteria, so which basically means that you have recurrent symptoms for at least 3 months. So usually abdominal symptoms, abdominal pain. The onset has been like more than 6 months ago, and usually with any kind of bowel movements, you got the symptoms, which is either diarrhea, you have the D-type, constipation, C-type, can have a mixed type of both, unclassified type, abdominal cramps, for instance, flatulence. So there are many, many different types. And basically, this diagnosis is an exclusion diagnosis. So you need to exclude actually everything else, like food allergies, food intolerances, chronic inflammatory bowel diseases. You have to exclude all of this. And then, when everything is excluded, according to the Rome 4 criteria, you can say it's an irritable bowel syndrome. And one of the reasons is also because we don't have a biomarker for it. We cannot make a laboratory test just saying, okay, it's irritable bowel syndrome, easy. It's not. We don't have it. And I can spoiler you, the gut microbiome test will not change that. It is not a test that can diagnose the irritable bowel syndrome. It's very important. It's one of my major messages. The thing what the gut microbiome test can do is, I think, in my opinion, more valuable than just diagnosing irritable bowel syndrome, because it can give us another information. And why is that? When you look at the different causes of, also risk factors of irritable bowel syndrome, there are so many. Psychiatric stage, metabolic stages, stress, very common, gastrointestinal infections, and basically the gut microbiome is one of the causes. Saying it's a multifactorial disease is one of the causes. It doesn't need to be a cause of irritable bowel syndrome in the individual patient that is in front of you. But it can be. And it is often the case. And this, basically, is one of the most important reasons to do a gut microbiome test, because we can basically recognize this, because there are certain constellations that are very, very common in patients with an irritable bowel syndrome. And also physiologically, this constellation makes a lot of sense. So one of the first things that you can see in our report, for instance, is the microbiome-associated health risk, which is a kind of general health risk association. In this case, leaky gut, I come back to that later. Leaky gut and the inflammation potential is increased because it is an inflammation-based disease. And that's actually what the gut microbiome in that constellation is doing. It makes a local inflammation, and this local inflammation makes the symptoms. Okay, and then it's typically that some bacteria are increased, like so-called LPS bacteria, lipopolysaccharide bacteria. This is also one lipopolysaccharide, one of the substances that makes us fever if they come into our bloodstream. Sepsis sometimes. Well, then there are bacteria that they protect the intestinal wall. Bifidobacteria, lactobacilli, very important. And then also you have producers of so-called short-chain fatty acids, like butyrat. A very important member, for instance, Fecalibacterium prausnitzii. If you read a bit more about the microbiome, you will come across this species, a very important one. Okay, and they produce that. And this is also very protective and anti-inflammation substance. And now the difficult part starts. You get an irritable bowel syndrome, or you're more likely to get an irritable bowel syndrome if you don't have them. So if you are just, the abundance is too low, because they cannot produce enough of this butyrate that protects us from irritable bowel syndrome and inflammation in the gut. But in case that you have too many, it reverses. If we have too many, these short-chain fatty acids actually open our so-called tight junctions. So it makes our gut leaky. And with that, I also will talk about later with a longevity talk because it's very relevant there. With this open gut, bacteria can come in to the intestinal wall and cause a local inflammation. Okay? And that's basically a problem. So you cannot just say, okay, it's always this and this and this constellation. Constellation can be different. Okay? And this is very important to detect because your therapy would be different. Okay? Important also, Methanobrevibacter, which is mostly associated with the constipation type of the IBS. Well, okay, when we have now used this gut microbiome test to identify the patients that have a gut microbiome that promotes IBS, can we change it? Can we change the gut microbiome and can actually we relieve the symptoms of our patients? The one therapy that has been mostly investigated in many, many studies nowadays, so there are many, many meta-analyses on it. So we have very good data. Of course, are probiotics. Not saying this is the most important way of modifying the gut microbiome, but it's for sure the best studied. And let's have a look at the efficiency. The efficiency, sorry, this is still in German, lactobacilli, bifidobacteria, and the combination of both, okay? So this is the efficiency compared to the placebo. Well, the placebo effect is already quite strong, yeah? This is a very, very big effect that probiotics have. And this has been shown in many, many meta-analyses and studies, randomized controlled trials. In Germany, this was the reason why we have a so-called S3 guideline. This is our highest evidence guidelines. And the S3 guidelines are usually very restrictive in terms of recommendations, therapeutic recommendations, if there is not a lot of proof. As the first guideline in Germany that recommends giving probiotics, in this case for irritable bowel syndrome. Okay, so because there's so much evidence. The only thing I do not agree with the guideline is the guideline says, okay, you give probiotics, and when there is a question, yeah, but which probiotics? It's an important question, right? They say, well, trial and error. Yeah, so we don't really know. Maybe you go for the symptoms, and but I think this is not enough, and this is basically also the reason why we have a lot of heterogeneity among the studies. So when we look at the meta-analysis, and they always come to one conclusion, one average result from many randomized controlled trials. So, and they say, okay, it's very good, it's very effective, but still, you have single studies that do not show an effect. And why is that so? Well, because in a study, each patient with an irritable bowel syndrome is given either placebo or one probiotic, one formulation, one standard dose. And that's a problem, right? Because first of all, we don't know whether in this patient with irritable bowel syndrome the microbiome is a problem. Maybe the patient has a wonderful microbiome. There is no problem. Why treat the microbiome? Of course, you do not see an effect. It's even worse. Yeah? You might see side effects in this patient. And of course, the patient pays for the treatment, and it doesn't bring anything. And then there is also the risk that by just giving probiotics, just something, while it works on the average, it might deteriorate the symptoms of your patient. Because of what I just said, imagine a patient that has a very high amount of bacteria that produces butyrate, and that's a problem for this patient because it makes the gut leaky. And now you give a probiotic, and this probiotic promotes the growth of exactly this bacteria. What might happen? Might be that the symptoms deteriorate. That's a problem. That's a real problem. Also very interesting, a long time there was the question, how does stress make us irritable bowel syndrome? Because it's something that, it's not very objective. We cannot really, measure it in a way. And it's very interesting that bacteria react to our stress. Not in the way that they are stressed, but in the way that they produce different metabolites. So what they're doing when a human experiences stress, they produce more indole-3 acetic acid. And this acid is very bad for the intestinal wall. It causes inflammation there. And lactobacilli are doing this. Lactobacilli. So imagine you have a patient with a lot of lactobacilli, which in truth has stress. And this is one of the pathogenic mechanisms. And now you give a probiotic with lactobacilli. Not good. It might be that your patient will not benefit, but even deteriorates. Yeah? And this is the reason why we also came up with a therapeutic team, actually, how to treat the gut or the irritable bowel syndrome based on the gut microbiome test in order to increase the chances that the probiotics that you give will be effective in an effective treatment. So first of all, if there is no constellation of a gut microbiome that might cause irritable bowel syndrome, no treatment. Of course, you look for other reasons, like for the leaky gut, you look for other reasons of the irritable bowel syndrome, but you do not modify the gut microbiome. There's nothing to modify. It's pretty much good. Okay? But then, for instance, if you have low lactobacilli, which is a problem, but okay number of bifidobacteria, you give lactobacilli because it's what your microbiome mostly needs. Yeah? The others is okay. And it has been shown in the studies that giving one group of bacteria is in irritable bowel syndrome more effective. So not giving combinations when you know that something is missing is much, much more likely the better way. If it's the other way around, low bifidobacteria, you give bifidobacteria. If both is low, of course you give a combination of both. If both is normal, it's a bit more difficult in this case. You can treat according to symptoms. So our report gives suggestions for alternative probiotics in this case. But the probably most difficult case is what I have just told. If you have an increase in butyrate-producing bacteria, in this case, do not give lactobacilli on probiotics. Never ever, because they promote the growth of them. And you will deteriorate the symptoms. There are other possibilities, like for instance, Bacillus coagulans have been shown to be a wonderful option actually in the treatment of the irritable bowel syndrome. So, and with that, I like just to sum up a few just general recommendations when it comes to probiotic treatment in irritable bowel syndrome. But I see you take pictures. Of course, I will also provide you with a handout later on. Okay. Of course, you can take pictures, but just knowing that that you will have all the slides. I always recommend, and I have a very good experience with that you do not start with a full dose of a probiotic. So for the first 2 weeks, start slowly, because at first it often, which is normal, can when the treatment is starting, it deteriorates. The first 2 weeks, it might be worse. According to what we often have, first it's getting worse before it's getting better. Okay, this is also here the case. Treatment itself, not more than 8 to 10 weeks. Theoretically, you could do that as a lifelong treatment, but it has been shown that the effect is getting smaller and smaller after time. Yeah? So my recommendation is, after 4 weeks of treatment, which is the time when most of the patients experience basically a change and see that it is really getting better, that they are told, okay, the thing that will change your gut microbiome very effectively in the long term is a change in your diet. And depending on the gut microbiome constellation, different forms of diet might be useful. Mostly Mediterranean kind of style diet with a lot of fermented food is usually a good choice, but doesn't need to be the case, but usually a good choice. When it comes to probiotics, one of I feel the most common mistakes is that they are given in a too low dose. So imagine, I just said there are 39 trillion bacteria in our gut. Now the recommendation and what we have seen from different studies is that you should give at least 1 billion CFU. Okay, we are in the promille region here. Yeah, so that is at least dose. It's very important to look at the preparation. It's even better to give 10 million per day. Okay, very important. Okay. So usually 4 weeks after stopping the probiotic treatment, you can, of course, check for the symptoms. Usually the patient would say that's very fine now. Basically also when long-term measures have been taken. If this is not the case, if the treatment has failed, that would be basically here the only reason to repeat a gut microbiome test, because there are two possible things that can happen. The first thing is that the gut microbiome has not changed because of colonization resistance. So then you have to do something else, maybe another probiotic, maybe another treatment strategy, maybe another dose. Something else must be used. Okay? Or the gut microbiome has changed and is not attributable to irritable bowel syndrome anymore. If this is the case, you have done here everything that you could. If the patient still experiences symptoms, it is because there's also something else, which might be the case, in an individual patient. Okay, so now I come to some cases that we have experienced with some colleagues, and there's a history of a 37-year-old woman. She has a management position in the catering industry, so she's very much under stress, which is likely also a reason for her symptoms. According to the Rome 4 criteria, she has irritable bowel syndrome, no other things, no chronic inflammation diseases, no food allergies, nothing. Okay, so in this case, a gut microbiome test has been performed, and the result is that she had actually, based on the results of the gut microbiome, an increased risk, actually very high risk that this gut microbiome constellation would promote the irritable bowel syndrome. In this case, sorry, it's in German. Of course, you will get it in English, the report. The butyrate-producing bacteria are very low in this case. This is one of the results. Also, bifidobacteria are low. Typically, this combination, lactobacilli are normal. You have in your whole constellation also a leaky gut risk. This is a typical situation that you have. And it's also a very easy one because low bifidobacteria, normal lactobacilli, and in this case, you can, and this is your best chance due to that report. You know it's good, you should treat this patient. And the second thing, you give bifidobacteria. And one of the best one is bifidobacteria bifidum. And this special strain here has been used in many studies, been shown to be very effective. Yeah? Again, at least a billion CFUs per day, 5 to 10 billion would be even better. 8 weeks of treatment. In case it doesn't work, in this case it has fantastically worked, but in case it doesn't work, Bacillus coagulans is always also a good alternative. And in case you have a complete treatment failure, you don't know what to do anymore, you also realize you cannot change the gut microbiome, even not by dietary interventions, which are usually also very effective. One way would be to bring the gut microbiome down that is just existing. And this is something that could be done by rifaximin, which is an antibiotic given for 2 weeks. It brings it down. Afterwards, you restore the gut microbiome by probiotics and by a certain treatment. I will not recommend that as a first action. It is discussed whether this would be a good idea to do in the first place. If you see that your gut microbiome is not good, I don't think that is a good way. I think at first we should, in a natural way, try to change the gut microbiome, because when we bring it down, we might also bring down the good things, and we never know whether they come back. And that's the reason actually for it. Okay. Second case. In terms of the history of the patient, almost similar. 51-year-old patient, Also a manager, a lot under stress, Rome 4 criteria, he has irritable bowel syndrome, also no other things. And so doing a gut microbiome test gets you actually kind of the same, but the other way around. Butyrate-forming bacteria are not low, they are high, okay? You have normal bifidobacteria, you have a normal lactobacilli, but you have a very high risk that this gut microbiome would contribute to irritable bowel syndrome. Well, but in this case, as I have already mentioned, albeit it seems similar, it is not. It's totally different. You have to treat absolutely different. In this case, you do not use bifidobacteria lactobacilli. They will promote their growth. Not good. Use Bacillus coagulans, for instance, and then the rest applies basically the same. Always use a high dose, and do not treat forever if possible. And in this case, it was also very successful. Okay. This information that I just tell you, our whole diagnostic and therapeutic algorithm, you will find on the report. I mean, this is the case. So the report has several pages. The first pages are some information about the single bacteria and groups that are deviation, or where you can see deviation or not. But I think the three most important pages would be the last three, where we give therapeutic recommendations as in a form that the whole constellation is interpreted. And of course, it starts actually with a nutritional concept. Well, because this is the one that is in the long term most effectively. Prebiotics, which is actually food for bacteria. If we eat probiotics, we promote the growth of special bacteria, and this is also shown here. I have either some preparations or also some special food. And then, of course, what I was talking about, probiotics. And then it is exactly written which strains are actually for which situation is good. For instance, if you have irritable bowel syndrome, it's more like this recommendation. Or if you have kidney stones, more like this recommendation. If you have an inflammation-based disease, more like this, okay? And with that, you will get the information extracted from the gut microbiome constellation and reported here. I would also like shortly to mention pre-analytics, just shortly, because I usually get a lot of questions regarding pre-analytics. And this is a package that we're going to have. I mean, obviously, the most important thing is the stool tube, where the stool has to be filled. Of course, there's a manual, a short manual that explains it to the patient how to do that. And everything that is needed to get the sample is basically in there. The thing is that is maybe also quite important once you have it in that stabilizing buffer, it is very stable, even for a year. So if there is a problem during post-transport, that's not a problem. So the DNA, RNA is stabilized in it. I think that's very important to know. And the other thing that is important to know, because this is always a very important question, when do I make a gut microbiome test, under which circumstances? And the best time to do that is the usual time of the patient, so when there is nothing special. Yeah, so the daily life. Of course, if there is now something, if the patient gets diarrhea suddenly, and it's not the diarrhea that he might be complaining about, irritable bowel syndrome, or is having some other need for medication like proton pump inhibitors or any antibiotics. Of course, all kind of acute medication is not good. Under acute medication, please never do a gut microbiome test, because you always want to do the test under, let's say, standard living conditions for the patient. And that might also be under a long-term treatment. Of course, if the patient gets statins, and this is the daily life of the patient because the patient needs statins, yeah, okay, then it will influence the gut microbiome, yes. And of course, after the result, we might talk about whether to remove the statins or not, whether this is possible or not. But at that point, it is important that it is measured at the daily life situation. So, and with that, I come to the second example, and this will be endometriosis. Endometriosis is a very nice example for a systemic impact of the gut microbiome. Right? And it is also a very nice example anyway, because like the irritable bowel syndrome, it is a very common disease. It is not like that it is often diagnosed, but in Germany, it's been known that about 7 to 15%, the big span already tells you, not so sure, yeah, but we know it's a common disease. 7 to 50% of women that are in a sexual maturated age have endometriosis. So this is really, really a lot. And just to wrap it up, what basically happened, the uterine tissue, the endometrium, it travels throughout the body in the pelvic cavity, in the abdomen, and there it forms endometrial lesions. Okay? And they grow and become very active during the hormone cycle, and therefore the complaints are very, very often during menstruation. So it's menstruation dependent quite often, and basically also these endometrial tissue, it can also bleed, and that's the reason why these blood-filled cysts are forming, yeah, on the tubes, on the ovaries, which is also very, very often reason for sterility in women. Actually, it's estimated that about every second woman that experiences sterility probably has an underlying endometriosis. It's just almost never diagnosed, or it's like very rarely diagnosed, or at least it takes a long time. In Germany, the average time between first symptoms and diagnosis of endometriosis is about 10 years. Diagnosis is very difficult. What about you? What you say?
I think it's a very, very long period to establish diagnosis. Should be much earlier.
Yeah, it should be much earlier. Absolutely, much earlier. But the fact that it's not, and so this poses, of course, a big problem. Also, the treatment is mostly surgery, but also hormone treatment, of course, also painkillers. Nothing of this is something that can be considered like 100% effective treatment. Often it comes back, yeah? Also after surgery. And so this is a problem. And now the question is, what has a gut microbiome to do with endometriosis, and how can that be helpful, this knowledge? Well, when we look at the pathogenicity and pathogenesis of endometriosis, it has been known for a long time that the so-called retrograde menstruation is a common reason, which basically means that these endometrial cells, they wander through, they just basically go retrograde. They go to the abdominal cavity, pelvic cavity, and there they form these endometrial lesions that actually cause endometriosis. Well, the thing is, 90% of women experience retrograde menstruation, but only 7 to 15% are having endometriosis. Well, so there must be something else, something that promotes it. And this has been very nicely studied now in relation to the gut microbiome. Gut microbiome dysbiosis is a very big driver here. And the reason, therefore, is that if you have a certain constellation, so first of all, again, you have a constellation with many inflammation-promoting bacteria, like LPS bacteria, okay? On the other hand, again, your protective bacteria, like the butyrate-forming bacteria, that would protect from them, they're low. Altogether, you have a leaky gut, which means that bacterial parts come through the gut and get into the bloodstream, like the LPS. And this is not only compared to the irritable bowel syndrome, which is a local inflammation. This is now systemic inflammation. It promotes, it activates the immune system all the time, basically. And this promotes all kinds of inflammation-based diseases, also other diseases, like rheumatic diseases, cardiovascular diseases. But in this case, endometriosis, because this cytokines, the pro-inflammatory cytokines that are released now due to this mechanism, they promote the adhesion of the endometrial cells to the pelvic cavity and also vascularization. So basically, that's the main mechanism how these endometrial lesions are formed regarding the gut microbiome. It's the most important way. There's also another way, which has been studied in the last years. So usually we regulate our estrogens via the stool. So we excrete estrogens via the stool. Men and women, both. Okay, and this determines the quantity of estrogens in our blood. A lot, basically. And the thing is, some of the bacteria, they have an enzyme, beta-glucuronidase it's called. And this beta-glucuronidase is able to metabolize the estrogens in the stool in a way that they are not excreted, but they are reabsorbed into the bloodstream. And this is something, if you have a lot of them, which is called a high estrobolome, which increases actually estrogen levels. And this is also known for endometriosis patients. They have higher estrogen levels, and these estrogens, they promote, again, the growth of the endometrial lesions. Okay? So inflammation, on the one hand, caused by the gut microbiome, and a metabolic mechanism is doing this. And this is also the reason why we do see typical constellation for endometriosis that looks basically very similar to the one of the irritable bowel syndrome, because the mechanism is not so different. And it is also not random that endometriosis patients have a 2 to 3 times higher risk of having an irritable bowel syndrome compared to non-endometriosis patients. So, because it's basically the same, you have a high risk of inflammation, you have a high risk of this leaky gut, so that everything goes through the intestinal barrier. Again, you have a lot of LPS bacteria, and the good bacteria, they are like they are lower, like the Bifidobacteria, Lactobacilli. And then again, the same constellation here with the Butyrate-forming bacteria. Too low, not good. Too high, not good, because too high would also open the tight junctions, come back to that later, and would promote inflammation and the estroboloma. This is special here. It's a special analysis is increased in endometriosis patients. Okay? So, as with the irritable bowel syndrome, the question is, what can we do? Can we do something? When we modify the gut microbiome, will it change the symptoms of our patients? The answer is clearly yes. It has been nicely studied. Basically, a lot of studies actually have shown this. This is my favorite one here from 2011, actually quite an old study, as you see. Sometimes all this knowledge is not new. It is just not used. Yeah? And, well, what they have done, they have used a very special strain of Lactobacillus gasseri. Yeah? And they have given, or they have with 100 milligram for 3 months. And what you basically see compared to the placebo, that the symptoms, dysmenorrhea, pain during menstruation, was statistically significant, much better in the group with the probiotic. And I like this study so much because they have not just given any probiotic, like any strain. They have shown the mechanism before, in a mice model in this case, because they have shown that this strain, specifically this strain, can activate natural killer cells. And natural killer cells are one of the biggest enemies of endometrial lesions. They bring them down. It's our innate immune system. It can bring them down. At least it can make them smaller. Maybe not making them disappear totally, but it can make them smaller. And they promote this growth. And they activate them, right? And also other studies have actually nowadays confirmed that, that a Japanese study here. And I think this is very important to know that this is working. And based on this, we do have, again, an algorithm here. Of course, if there is no constellation that indicates that endometriosis is promoted, of course, no treatment. If Lactobacillus gasseri, because it has a very special bacteria for endometriosis, if this is reduced, of course, giving a high dose of Lactobacillus gasseri is a good thing. Lactobacillus are reduced, give lactobacilli, but always Lactobacillus gasseri with it. And there's also the case of butyrate producing are reduced. This is also a very typical constellation, actually, which can be given always Lactobacillus gasseri, Lactobacilli, bifidobacteria to promote their growth. But again, if the butyrate producing bacteria increased, mostly this is the case if the estrobolome is also increased, because basically same bacteria that have that enzyme, the beta-glucuronidase. Better do not give lactobacilli and bifidobacteria. Exception, Lactobacillus gasseri, and then in combination with Bacillus coagulans. That would be probably, in this case, very, very best combination that you could do. Okay. So, and this is actually a summary of the probiotic therapy here. So, if you have the situation that you have an inflammation apart from the probiotics that you give, it's always a very good idea to change in these patients to a diet that is not promoting inflammation. Mostly, this is something like a Mediterranean diet, a lot of omega-3 acids, and also vitamin D. I say this is something that you should give anyway, because many studies have shown that this is working. It's very important, because it brings down the inflammation. It might not treat the cause of the inflammation. Okay, if you know the cause of the inflammation is the gut microbiome, fine, then we can handle that. Sometimes something else that we might not be able to see. Okay, but in this case, this is something that that absolutely would help. And again, then there are the same principles. Start maybe with half a dose. Give at least 3 billion CFUs per day, and base the treatment on a gut microbiome report, because this personalized treatment is the best chance that it is working. Just never use Lactobacillus rhamnosus in endometriosis. Has been shown to be not effective, and sometimes also makes endometriosis worse. Okay, so I'd like to give you also some cases here. This was a 32-year-old female patient. She has already been diagnosed with endometriosis stage 2. Okay, so yeah, not the earliest stage, but also not totally advanced. She had already surgery, but so she has recurrent problems, which is not seldom actually. It's quite often the case. She refuses hormones. She also wants to have children, and she's using painkillers, and she has asked for help, and what we have done is a gut microbiome test, and as you see, she had basically the typical constellation, I would say. Typical constellation in this case, she had a very high risk for endometriosis that comes from the gut microbiome, so gut microbiome associated risk. Bifidobacteria, lactobacilli, everything was reduced. The estrobolome was increased. So a very typical situation. And in this case, what has been administered are bifidobacteria, lactobacilli, and also especially Lactobacillus gasseri, not rhamnosus. Must be a bit higher dose, even higher than in the IBS, because the IBS itself is local inflammation. But here we are even talking about systemic inflammation, okay? So higher concentration again, probably better. And what is different is that in the IBS it has been shown that a shorter treatment is probably more effective. In this case, not. It is probably a long-term treatment. You have to give it. Unless, of course, you can change the gut microbiome by other measures, like dietary interventions or something else. Okay? In this case, of course, then you don't need probiotics anymore. And this has helped in that patient a lot. So, but then there are other cases, like for instance, this 35-year-old patient with dysmenorrhea. She has not a diagnosed endometriosis, but she has symptoms that somehow relate to it. She's taking ibuprofen, basically a lot. And of course, she asked now whether there is something else, because ibuprofen has all sorts of side effects for her. So you're doing a gut microbiome test in this case, and this can happen. And that's why I also show you this example. It can happen that she has just a wonderful microbiome. Okay, there is nothing. So in this case, the gut microbiome is not a factor for her inflammation and for her endometriosis. There's probably something else that promotes her inflammation, but it's not the gut microbiome. Okay, so dysbiosis index, and always a 10, it means that basically it's normal biosis. There is nothing that comes into attention here. Okay, so no probiotic treatment. Of course, this is what I just said. What you can always do is change the diet style in a way that at least omega-3 fatty acids, vitamin D is given. This is what you can basically do as a kind of basis treatment, apart, of course, from painkillers and potential other options for this patient. But yeah, in terms of gut microbiome, nothing to do. So the good news that you have a good microbiome, sometimes bad news in this case, because no treatment option here, yeah, regarding this. Okay, and with that, I come to just summing up of the first part of my talk. So I hope I could have shown you that the intestinal gut microbiome, it's an organ, and we have to consider it as an organ. That's very, very important. It is a course, one course of irritable bowel syndrome in a local inflammation sense. It is also a cause of endometriosis in a systemic sense. And the gut microbiome test will not diagnose these diseases, but I think give you something that is quite valuable. It shows you whether there is a treatment option or not, whether this patient can be treated, and also according to the report, you will have an idea about the best possible treatment. You can personalize it because you have looked at it very, very detailed. That's very important, and this is even something that you could extend to other inflammation-based diseases, rheumatic diseases, cardiovascular diseases, very important, very inflammation-driven, dementia, and in the end, also aging. We come to that in the next talk. Yeah, good. And here, let's have a coffee break, right? Voilà, Lepo, for your attention. If you have any questions, of course, happy to ask.
There are many questions, but we will start.
Yeah.
First, you mentioned that is a minimum 1 billion of the CPU
Yes.
units in the treatment. But what do you think about the high dosage? Because some, especially some producer from Italy, recommend 100 billions of the
Yeah, that's what I'm saying. It's a kind of minimum. No? It is just because
system of triobiotics.
Yes. I think the higher, the better. Of course, if you give higher dose, you have to be very sure that it's the right thing. Because if you give the higher dose of exactly the probiotic that would promote the growth of the wrong bacteria, that would be even worse. Yeah. But generally, your chances of really modifying the gut microbiome, of course, increases with the dose. Yes, absolutely.
Also, you are a professor for microbiology.
Yeah.
And your concept of the endometriosis is excellent, except you missed, I think, two things. This is also microbiologist of etiology of endometriosis. Because in endometriosis we know now one viral presence of the herpes virus type 6, and the second recently fusobacterium. As opposed to the can cause the immunological cause of endometriosis.
Yes, yes. I didn't mention, because it makes things very difficult in terms of the pathogenesis. I'm also sure that the pathogenesis that I have presented is a part pathogenesis, as usual. Also because there are other reasons for inflammation. It is basically the same when, for instance, doing the research on morbus Alzheimer. It's the same when we look at the plaques in the brain. We find herpes viruses. We find different strains. If we look at the colon cancer, for instance, we find a lot of fusobacteria in the colon cancer. Yeah? Looking at the evidence, I'm at the moment not so sure whether we can now really draw the conclusion that this is a proof that they would promote these lesions, endometriosis, for instance, or colon cancer. It can be, I have the colon cancer, and because of the colon cancer and because of the whole changes in metabolism, the whole changes in immunology, basically, you have a change in the microbiome, and then this somehow attaches certain bacteria more than others. Yeah, and then we find it in the colon cancer. We find it in endometrial lesions. We find it in the amyloid lesions, for instance, in the brain. But we cannot. You're absolutely right. We can at the moment not exclude that. We do not only have a pathogenesis that is microbiome and so systemic driven, it might be also that certain pathogens drive it. If we would know more about it, that would be very good. Yeah.
Multifactorial causes of many diseases and many problems.
Yes, absolutely. Absolutely. If we would know that very much better, we could probably target it very much better, right? Yeah. Yeah.
Learning.
Is it okay some pause about 30 minutes to eat?
Sure. Sure. Sure.
Da li je u redu
Danach, eine Stunde.
napravimo jednu pauzu
Ja,
od
nach
pola
Plan, ja.
sata? Tu je preko okna ovde do nas je sala gde smo spremili jedan mali catering, da se poslužite, osvežite i da nastavimo još da sad iđu sledeći slučajevi. Sad je onako taj klinički deo možda i interesantni. Okay.
Well, honestly, everywhere I go when I talk about longevity, just general, not only about longevity in relation to the gut microbiome, I always see that practically everybody is very interested. I hardly see that in other talks, but longevity is something that catches really everybody in every age. And I think it is certainly for us all also a very emotional topic. And because it is an emotional topic for everybody, I think I can fairly say that there is in the history, the whole history of medicine, not a topic with so much spam like in longevity. Because we all hope for the best and we all want to believe. And the talk that I want to give you today is I would like to differentiate what is it that would really work and what is really important and what is basically scam. Here's one statistic. 60% of the US citizen take 75 or more anti-aging products. Yes, not only supplements, also mean any kind of lotions and stuff. So, and I mean, almost none of them has been proven to be effective in any way. Yeah? And despite that, it is just given. And this is what I would like to talk about today, of course, with a focus on the gut microbiome, and see what is a farce and what is actually truth. Okay, so what do we know and what do we don't know? And well, I think in a certain way, we know that there are things that we can do. If we simply look at certain developments, for instance, international sport professionals that have been retired maybe 20, 30 years ago, very early, not today anymore. Djokovic, yesterday, perfect game, perfect match. He's 37 years old. Oh, 38 now? 38 years old. Okay. Okay. So, even 38. And Boris Becker retired with 30. Okay. Also, in other sports, you find the examples. Cristiano Ronaldo. Also yesterday, unfortunately, he scored in the semi-final against Germany. Yeah, but amazing. Yeah, usually a footballer would retire also at about 30. And he's 40. Yeah, it's amazing. And there is something that you can do, and what these professionals are actually doing to keep the body young. Also to compete with the younger people, because there would be no other way. They would not be competitive. So the question that I would also like to answer, is this something that only like a kind of elite, super professional sportman can do, or is it something that everybody can do? Right? So, and when it comes to the gut microbiome, basically I like to talk first of all about, maybe a very short introduction, what is age? Because we have to think about this once. What is age? What is a biomedical age? Why is that important? And why would it be maybe a good idea to detect it? And then, why is the gut microbiome so important? Because it's basically, as you will see, the gateway, we also had that already, it's a gateway of inflammation into our body. And inflammation is basically cell aging. Okay? I will also talk about the relationship between the gut microbiome and cardiovascular disease, and about the gut microbiome and obesity, which is also a very, very important factor when it comes to aging, and again, also presenting new practical cases. But maybe first let's start, what is age? Of course, there is chronological age, our birth of date. Nobody argues about that. That's the easiest definition of age. And of course, we know that there is a difference between somebody in terms of risk of mortality, risk of certain diseases, between somebody who's 20 and 80. And of course, all studies that take that as a risk factors usually see age is a risk, chronological age. Coming from Kronos, the god Titan, as you see here, he's holding Zeus. He was for a long time, the king actually of all gods. But then there was a prophecy, and this prophecy said that one day one of his child will push him off the throne. So he developed a very bad relationship to his children and ate them. He missed one, that was Zeus. And Zeus actually banished him into the underworld forever. And that's why the chronology comes from Kronos. Yeah, the everlasting and ever ongoing time. And this is basically the age we mostly talk about, but is it the one that is most important when we talk about aging? Well, there are certainly other ages, because we know sometimes somebody who is 30 or 65, for instance, can be much fitter than somebody who is 50, with a much higher risk of certain disease like diabetes, cardiovascular disease. Well, so there must be something else than chronological age, and this is for sure the biomedical age. The biomedical age is basically the age that is, for a medical doctor, probably the most important one when it comes to his patients. Well, it is, you can, as you see in the picture, you can define it actually as a sum of risk of having an age-related disease in a certain period of time. So the higher the risk, the older I am. That's it. And this is also a very logical definition. You know, there was also in the US, they made a study. They had 40,000 autopsies, and they analyzed that. 40,000 autopsies, also of people who were 100 and older. And then they found out none of them died because of age. Everybody died because of a disease. So we need to talk about disease, and we need to talk about the disease risk for cardiovascular disease, for cancer, and so on. That's why biomedical age is probably for us most important. But a patient that comes to a praxis and is talking about aging, he's not talking about a biomedical age. He's usually talking about an emotional age. He wants into the fountain of youth. Yeah? And what does that mean? It's because it's very, very, very important. It means actually also most of us would attribute age to our own fitness. And that's a very, very important point. What do you think? There's been a study, and they have asked different people, if you can decide how old you get, what would be your decision? 65, 75, 85, 100, 125, 150 years, or eternal life? What would you say 3/3 of all person answered? What was the decision? Any suggestion? 85. Perfect answer. Yes, 85. That was the most common answer. For a clear reason. Because then they've changed the question and said, okay, what if we could stop any mental and physical decline? How old would you like to get? What was the answer? Eternal life, of course. Yeah, and that's it. So when we talk about longevity, and when it comes to us, we actually do not primarily talk about increasing the lifespan. We need to talk, first of all, increasing the health span. The lives, or the years of life where we are fit. The one comes with the other. But this is what also most of the patients basically want. And the good news for us is that the emotional life is, and there's also many studies shown, very much related to the biomedical age. If you have a good biomedical age in terms of low risk of age-related diseases because you're simply also fit, you also feel fit, you are more fit. And that's also the reason why the biomedical age is basically the one we need to target. And it's also good news, while we cannot change our chronological age, it's impossible, but we can influence the biomedical age. It is not fixed, even if it's not good now, it doesn't need to stay like this. We can change it. Okay? There's just a question, what would be an effective way of doing it? Because what basically modern medicine is doing a lot is we do focus on single diseases. We do our research, okay? Age-related diseases. And of course it makes sense because somebody has a cancer and of course we want to cure. It's an individual person and of course we want to help. But what do you think when we would cure cancer? From today onwards, no cancer anymore. Nobody has to die because of cancer. What would be the effect of life on our life expectancy? What is your estimation? So life expectancy is about, depending on the country where you look at, basically something like 80 years for women, 66, 68 years for men. What would be the increase? What do you think?
30 years might be.
30 years, 10 years?
0 to 2 years.
Thank you. Yeah, 0 is also, I know your idea behind it, but that's because that's the point. It's not a lot. It's 3 years. Yeah, it's 3 years. Because when we just cure one disease, okay, 3 years later we die because of another disease that we haven't cured.
50% of the male got cancer during their life, and two-thirds of the women, 70% got some kind of cancer.
That is exactly the reason why the result is very surprising. But again, there are so many other age-related diseases we might die of.
More people die from cardiovascular disease.
That's the point. 3 years later, cardiovascular disease come, and that's it. Yeah, and this is the point. So we need actually an idea how to stop aging in a way of cellular aging. And what research has shown that basically all age-related diseases are a lot driven by inflammation, which is also the reason why there is the term inflammaging. Inflammation is the way of aging. Cardiovascular disease, good example. Also, tumor diseases. Everything is promoted by inflammation. So reducing inflammation is the most important thing. Otherwise, we are basically doing what we are doing now. Do you know the child game? It's like, there is a little mole, it comes up a hole, and then you have a hammer, and then you just put it down. And once you have put it down, it's in there. And then another one comes up, and you just get to another one. And that's actually what we are doing. So we have a patient. The patient has a disease, age-related disease. We might be able to handle that, or we send them to a colleague, and then you push down the mole. And suddenly, just a little bit later, another mole comes up. Okay, it's another problem. Boom, 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 boom. Until it is so fast, you lose the game. Okay? That's what we are doing. And to have basically a way how to at least reduce the inflammation and the gateway to all these diseases, that would be something. And that's actually what we are going to talk about now. And before we do that, very, very shortly, I don't go into the details here. In my opinion, it's a very important thing when it comes to longevity to have a test to basically measure the biomedical age of an individual, because this is different from the chronological age. And this was been, we have actually generated such a test. It's called Chronovital Index. And it is based on a study of proteomic study. So what they have done, there were 40,000 patients, and they have looked at the serum proteins via proteomics. And they have seen that certain constellation of serum proteins are associated with certain risk of diseases. I know it's very small, I couldn't make it larger, but these are all age-related diseases, osteoporosis, ischemia, stroke, cardiovascular disease, type 2 diabetes. And you see, this is the age, and this is the appearance, the frequency of diseases. And you see there are different groups. The blue one, where even in young ages, they had a high frequency of the disease. Yeah? Then the green one, the best one, and the orange one in between. And this serum proteins, or this master, this was extracted actually by machine learning, could identify patients who are at risk. And this makes sense. It also makes more sense than, for instance, DNA tests, DNA methylation tests. And that is good because serum proteins, these are our effectors, the effectors of our body, right? So we have basically developed a test that is based on that validation study. By the way, 3 cohorts, British cohort, where the test was validated, and then the test was confirmed onto other cohorts from Finland and from China, so it even works in a totally other population. So this is really, really interesting. And what you basically get is that you have your chronological age, and you will see whether you are younger or older in terms of your biomedical age, based on blood markers that are highly associated with this proteomic study. So we will have this available at the summer. It's maybe something that is interesting because I think it is in a way interesting because you measure this biomedical age, and this is something that can show your patient where you are actually. And once you have that, this is somehow a motivation for treatment for these patients. I think this is something that has already been shown with the tests that are on the market, that it's a very, very high motivation for patients to do something, and also to change lifestyle, and of course also other measures, so lifestyle and other things. And in the very end, this is also something that could be used then to control what are the results of these measures. So of course, nothing that you just change your lifestyle and you make the test in 4 weeks. I mean, nothing, of course, happens. You have to wait at least 6 months, probably better a year. Well, but now let's talk about this inflammation, which is, by the way, something that even artists have as a motive. It has been so, it's getting quite popular. But, we have basically to ask ourselves, where does it come from, the information that is, by the way, often silent for many, many years. Nothing that like an inflammation that we have from infectious diseases is coming up immediately and it's getting us sometimes numb. No. It's often silent and poses therefore a big problem. And then there's also the question how, or is there something that can increase this inflammation? There are different sources of inflammation. The one source that I would like to talk about today is, of course, the gut microbiome, because I have already mentioned it as a potential source of inflammation. And I would like to have a bit deeper look at the leaky gut that I have already told you about. So basically, this is, the anatomy of the intestinal wall. Just a little illustration. What you have the mucus, which is very protective in terms of that it is a kind of filter or a kind of protection function that the epithelium, which is of course very important, and the true protection barrier is somehow not in direct contact with the bacteria, okay, and all the microorganisms. Of course, the epithelial barrier, this is the barrier to the outer world. It pretty much regulates a lot what kind of food or what kind of other environmental molecules we will let into our body or not. And then we have actually the tissue, the lamina propria, starting with cells of the immune system. So everything, so fine. Most of the transport is basically regulated via the epithelium barrier, transcellular, by some receptors, transporters, okay? But it can be useful for the human body also to transport things between the cells, transcellular. But this is something that is usually very much limited through the tight junctions. So what are basically the tight junctions? You can imagine these are kind of protein threads that are, or that basically can attach the cells together or loose them. So make a kind of hole, or actually really close the connection between the cells. It is regulated by different by different regulators like occludins, claudins, and the relation to the gut microbiome is that the gut microbiome is able to regulate these tight junctions. Not only we as humans can do that, also the gut microbiome. Some structural components, for instance, open them. These are the ones that have the red arrow here. They open tight junctions, okay? Again, lipopolysaccharides, the one that are very inflammatory. Flagellins, this is a substance that you have in many pathogenic bacteria, okay? Well, also their metabolites. Some of them can close them, and if there are many, it opens them again. The short chain fatty acids. That's what I was talking about before, okay? Too many of them would open them, and too few of them would not be able to close it, okay? You also see that many polyamines, for instance, are able to close the tight junctions, something that you find in the Mediterranean diet a lot with olive oil and many food in that kind of diet. So, well, meaning as long as you have a normobiosis, or we also call this a symbiosis, sorry, this is German, I will explain it, the tight junctions are very close. So none of the bacteria, none of the food, nothing can come through. You have a tissue that is not, where there is no inflammation, okay? But once the tight junctions are open, bacteria come through, food comes through, all totally unregulated. Environmental substances, molecules, everything can come through. It even destroys the epithelium, which opens it even more. So the result basically is local inflammation here, something that could promote to a irritable bowel syndrome, but also this inflammation, or this LPS, it goes into the bloodstream. Once it goes into the bloodstream, systemic inflammation is promoted. Like all systemic diseases, cardiovascular diseases, dementia, all age-related diseases are basically promoted. And as I told you, the gut microbiome test can make this visible, and there are ways to treat that. Yeah. You, for instance, see this here. Increased leaky gut risk. Okay? And here it's even now a bit larger. Sorry, this is in German. Of course, will be in English on the report. So an increased leaky gut risk. Again, there are more reasons than one for a leaky gut. It's not only the gut microbiome. So the gut microbiome is not the test to test for a leaky gut. If you want to test for a leaky gut, you have, for instance, here nice options. Alpha-1, antitrypsin, sonulin, these are actually components that are usually used to diagnose a leaky gut. The gut microbiome test can tell you whether your gut microbiome contributes to the leaky gut or not, because there are other reasons that could cause a leaky gut. Medication, stress, even certain food actually can do this. Okay? So you have basically a way to test for it. And then there's a question, is it, because we have shown that many of the systemic diseases can be treated with probiotics. One example was endometriosis. If we have a leaky gut, and if the leaky gut is promoted by the gut microbiome, but also other diseases. So this is an interesting study here. It's a meta-analysis actually, and they have looked at inflammatory arthritis. So basically rheumatic diseases, different rheumatic diseases. And here I have one example, and this is psoriasis arthritis. And they have given the patients probiotics and have seen whether this is effective. And what's interesting, they in these two studies at least here, they've looked at the PASI score, which is actually the psoriasis area and severity score, which shows how severe are the symptoms. Okay? Giving probiotics compared to the placebo has reduced the symptoms. In one study, about 37%, in another one of 51%. That's not bad. And I would claim that PASI 75, reducing the symptoms about 75%, would be absolutely possible. This is the aim that at least the German guideline is calling for. And why is it possible? It's because, again, in these studies, patients have just received probiotics. Nobody has ever looked if they have a problem with the gut microbiome. So they were, of course, patients that had never a problem with the gut microbiome. So, and then again, also, they might have not been treated with the perfect probiotics for their certain cases. So this is something that shows that you can bring down inflammation with probiotics if the gut microbiome is actually your gateway. Okay? So microbiome modification treatment is working. But the inflammation thing is not the only thing that is important when it comes to age. There is also another very well described association between the gut microbiome and cardiovascular disease. And this is what you can see here. It is more a metabolic pathway, which is also very interesting. When you eat a lot of food with L-carnitine and choline, it's a lot red meat, mostly red meat, but also others have it. And you have certain bacteria in your gut, perhaps Streptococcus, Clostridiaceae, they are able to transform this carnitine and choline to a substance which is called TMA, trimethylamine. Our liver oxidizes it to trimethylamine oxide, TMAO. And TMAO is very well known to promote atherosclerosis. So basically, the constellation of the gut microbiome can also promote cardiovascular disease, even in a non-inflammation manner, which is very important. And you can see that. You can see these TMA-forming bacteria. This is, for instance, one report where you also see that the cardiovascular or microbiome-based cardiovascular disease risk is quite high, because inflammation is there, which drives it a lot, but you also have the TMA-forming bacteria, which are basically increased. And the question is, how important is it? I mean, it could be a small contributor to cardiovascular disease, but could also be a very important contributor to cardiovascular disease. Let's have a look at these meta-analyses. The meta-analysis, okay, result is shown here. Maybe I showed you immediately. It shows that the increase in TMAO levels in the blood would increase the risk of cardiovascular mortality by 91%, almost doubles it. What about the so-called LDL cholesterol? Yeah, question?
How come this is not recognized as a risk factor for cardiovascular?
There are so many other risk factors that are not recognized. We very much focus on LDL cholesterol a lot. You look at LDL cholesterol, there were almost no studies that have investigated what is the importance of LDL cholesterol regarding cardiovascular mortality. They always look for cardiovascular events, which is fair enough. Okay, yeah, sure. But when looking for cardiovascular mortality, it was only 21%, and TMAO was much more important. And it is also concentration-based. You know, the more TMAO you have, because this is 91% is almost doubling the risk. Okay, and it's just here, but many patients have even more, 8 times more, 30 times more. So it is very, very important. I think LDL as a marker for cardiovascular risk is not very good. Not only because of this result, because you can have an LDL that is not oxidated, that has not, like it's not packed in very small dense particles. It's not contributing to atherosclerosis. So that's why it's still a marker. It's still a marker, and of course, if it's increased, you have to take it seriously, sure, but it's by far not the only one. Yeah, and this is something that can show it, and I think it shows that the cardiovascular risk that can come from the gut microbiome can be much higher than the one that comes from the lipids. Well, so unfortunately, you can also do something against it. While lactobacillus rhamnosus was not such a very good idea for instance, endometriosis, it's a much better idea for TMAO, has been shown to change the gut microbiome in a way that it reduced it by 26%, and this is something. Well, and now let's talk about another global problem, a global problem that contributes to aging as no other problem. And this is obesity. When we look at obesity, I think, while still having the corona pandemic in mind, which of course has hit us, but the ongoing pandemic that really, really, really so much contributes to our mortality is obesity. And obesity is a huge problem in many, many countries. As seen here, unfortunately, Serbia is not within there, but so you see, US, there are more than 35% of people are obese. Obese defined a body mass index more than 30. Overweight would be more than 25. In Germany, which is also not very good, in the upper midfield, actually it's 24% of people are obese. 67% of male would be overweight, and 53% of women are overweight in Germany. So it's a huge problem. It's also recognized now by the WHO as a disease on its own, obesity. But of course, a risk factor for almost all kinds of important diseases, like cardiovascular diseases, diabetes, rheuma, depression, all kinds of diseases. And the reason, therefore, is that our fat tissue, especially the visceral fat tissue, is metabolically very active. It is the one that causes most inflammation in our body. And this inflammation contributes again to these diseases. Because when people come and maybe ask about, well, I want to lose weight, usually they do not think so much about the health aspect. They think more about the cosmetic aspect. But still, there are a lot of people who want to lose weight and who also do this in a very consequent way, but they cannot. Sometimes they're doing diet, also really calorie restriction diet, and they even gain weight. And of course, they're desperate. So, and this is something that has not been answered for a while. And then there was also the question, the gut microbiome, it has to do so much with metabolism. Maybe it has to do something with this problem. And basically, there was a Nature study in 2006, and this study was a kind of revolution regarding that topic. Well, they had genetically engineered mice. Well, this one here, they have no leptin. Without, because knockout genes, okay? No leptin means they are always hungry. They eat and eat and eat, and that's why they become fat, as you see. While the normal mice with leptin is lean. The first thing what they did, they have investigated the gut microbiome and have seen changes between them. The fat one had much more Firmicutes bacteria. You have to imagine this is a very, very broad categorization of bacteria. And these bacteria are very, very effective in breaking down carbohydrates. So basically, they can very nicely and very efficiently extract energy from our food. At some point in the history of mankind, that might have been an advantage to extract a lot of energy from the food. So this collaboration with the bacteria was a good thing. But nowadays, where we have like an overload of food, and this is not such a great thing anymore. But of course, it still was not a proof. So what they have done then, they said, okay, let's take germ-free mice. Germ-free mice are mice without a gut microbiome. They are sterile in their gut. So you can engineer such mice. And what they have done then, saying, okay, let's see what happens if we make a fecal transplantation from the fat mice to the germ-free mice and from the lean mice to the germ-free mice. And let's see how they develop. And this is how they developed. These germ-free mice have gotten exactly the same food, both groups, exactly the same calories. But the one that have received the gut microbiome from the fat mice, they gained much more fat and body weight compared to the one that have gotten it from the lean mice. So there is something to it. And this study that was a kind of explosion causing study, a lot of studies basically followed. And so the first studies, of course, were very simple. So again, sorry, this is German, but I translated for you. What they have basically looked at is whether the gut microbiome of obese persons and lean persons have differences. And they have found a couple of differences. Again, the Firmicutes bacteria that are important for extracting the energy, they were increased. And again, the bacteria that are causing a lot of inflammation, the LPS bacteria, they were increased. Others, like Bifidobacteria akkermannsia, were decreased. And again, our a bit diverse producer of short-chain fatty acids, it was both. So I think what all these studies have shown, certainly that there are differences between lean, obese, they exist, but it is more complex. These differences are somehow also distinct, that meaning that there is not the one gut microbiome that an obese person has compared to a lean person. Basically also the same like in IBS or endometriosis, as we have seen before. There is not the one master that is always there. It is different. But this was very encouraging, and well, the one thing that somehow convinces me that there is something to it are, of course, clinical trials. Because we always have to ask ourselves the question, whether the gut microbiome changes that we see have caused a certain phenotype or a certain disease, or whether it is a result of this phenotype and the disease, right? I mean, it could be that I've become obese, and because of that, because of my lifestyle and all the changes associated with it, of course I have another gut microbiome. So this is something that needs to be ruled out. And because of this 2006 studies, there were so many randomized clinical trials ongoing that have investigated that effect, and it is very, very safe to say that there is something to it. But we really have to understand what it basically can do. So what they have used in this is probiotics, prebiotics, so probiotics on the one hand, and also combined with the prebiotics. So these are the food for bacteria. Together you call that symbiotic. Okay, and they have shown that statistically significant, the administration of probiotics and symbiotics can reduce the body weight by 1%. So, well, not so much. If it would be more, I wouldn't talk about it because you would already know. Everybody of you would know. Of course. It would be very, very easy. But that's not the way how it works. It has been shown that in all the studies where you do not only administer probiotics or symbiotics, but where also basic measures of weight loss, like more exercise, change in diet, calorie restriction, in these studies, you have seen an effect. The average effect was a booster of 24% more weight loss due to that measures. Okay? I know it's probably a good idea to have an example here. Again, very sorry, this is German illustration, but I explain you. Imagine you have a person 100 kilogram weight. This person has a gut microbiome that is not in favor in terms of weight loss. It is a gut microbiome that hinders the weight loss. Okay? This 100 kilogram person would change the diet because of this, losing 5 kilo. Would make more exercise, losing another 5 kilo. So because of the basic measure, this person loses 10 kilogram of weight. But since this person is hindered by the gut microbiome and cannot reach the optimal weight loss, if this person would have treated with a microbiome modification treatment, probiotics, or better in this case symbiotics, it would have gained another 2.4 kilogram, 24% on the average. The thing is, it was not the upper 95% of the confidence interval. So the effect in the optimal case is even much higher, has been shown in the meta-analysis. This is about 46%. So approximately 5 kilogram more weight loss if this person would have optimized the gut microbiome according to the weight loss. And this is a very good described mechanism behind it. And the mechanism is shown here. It is very much, again, about the short-chain fatty acids. They are one of the, probably the most important metabolites of the gut microbiome. What are they basically doing? If you have strains that produce them, they do something. They bind to a receptor in the intestinal wall, and this receptor is able to promote the release of PYY, that's one thing, and GLP-1. Maybe you have heard of GLP-1, glucagon-like peptide 1. So very important. Don't know how much you use it here, the agonist? Yeah, okay. It's basically doing what semaglutide, for instance, is doing. Yeah. You have an appetite loss centrally, this is one thing, and the other thing is that it slows down your bowel movements. So you have less appetite. And of course, with having less appetite, your chances of being consequent during a calorie restriction diet is much, much higher. Yeah? And for that reason, you can go through it. It's much more likely. It's a kind of, a kind of intrinsic injection of Ozempic, if you want, having a good gut microbiome. But it's not the only thing. There are also other things like the leaky gut again, because something like inflammation would promote also lipogenesis. And again, too much of the good thing, like short-chain fatty acids, is not good, because the short-chain fatty acids, like butyrate itself, are highly caloric. So if you have too many of them, again, that this is the case when you really extract them also from the carbohydrates, this is something that can be a bad thing in terms of weight loss, because they are so highly caloric. So you have to be careful about this. And this is also basically the reason, if the question is how can the gut microbiome test contribute to weight loss? How can that help? Well, it would, first of all, again, identify all the patients as have a deviation in the gut microbiome that would contribute to obesity or like hinder actually weight loss. So you would extract the persons where actually a treatment is not useful. It increases the risk of side effects by 21% if you just give a treatment that is not useful. Sometimes symbiotics or also probiotics can also be counterproductive, because again, if you have too many short-chain fatty acids, it could contribute to obesity. So that's basically not good. And with the gut microbiome test, exactly as with the irritable bowel syndrome, you can identify the symbiotics that are most effective to bring it into a good direction, and not only to reach the 24%, the average, but even go within optimation more for the 46%. But of course, this is not the only thing. There is something that needs to be considered. There is a so-called meta-regression, and in this case, it has been looked for many other variables that were also important in terms of the treatment when it comes to weight loss. And of course, it was very effective if the BMI was more than 30. Of course, you start with more. Again, treatment duration should not be too long, because often you promote a certain gut microbiome, which maybe then produce again more short-chain fatty acids in the long term. Preparation treatment was much better. This is not the same, like irritable bowel syndrome is not the same. It's much better to focus on certain groups of bacteria, but here not. Combination treatment is good. And again, a higher dose, actually basically much more than this, but this is a cutoff that has been used in the study, would be good. So, so the result actually is treat with a combination treatment for less than 12 weeks with a dose that is high enough. And if we actually sum this up as a kind of recipe, so first, most important thing, just giving symbiotics or probiotics will not do a lot. You have to combine it with the basic measures for weight loss, more exercise, diet. There is nothing that goes around that here. Symbiotics were more effective than probiotics, mostly with inulin, or for instance, galacto-oligosaccharides, fructo-oligosaccharides. That was a very good thing. Preparation that contained more species were also good. And again, I recommend a higher dose. Yeah. And do not treat too long. There is the option to treat longer than the 12 weeks, of course. Sometimes, because changing of diets and other methods might be not that working that fast in the patient, you can, but then you should reduce it. So like treating for like 24 weeks instead of 12, you reduce your dose by half. Yeah, make it easy. So 1 billion. Okay, so, and that will be very effective. Of course, change in the diet, also like fermented bacteria. This is something that is highly likely to work. So, and here are some cases now where this really worked nicely. So this was a 42-year-old woman. She had a body mass index of 29, so not obese officially, but overweight. She had no type 2 diabetes. So she wants to lose weight, yeah, for health, but also for cosmetic reasons. And she has read a marketing brochure where Lactobacillus gasseri was promoted as the one solution to lose weight. She took it and there was no effect. So now she came and said, oh, well, what's wrong? And yeah, a gut microbiome test was done. Apart from the fact that it couldn't have worked anyway, because without other measures, it cannot work. It turned out that her gut microbiome was totally okay. So the microbiome-based risk for obesity, so again, it's German, was very low, so green. Okay, and everything that is important here, LPS bacteria, lactobacillus bifidobacteria, certain ratios, everything okay for her. So of course, for her, the only measure is to actually make a real diet. She has never done that. She just took the probiotics and thought, oh, that should work, but it cannot. Okay, and in this case, there's also no reason in modifying the gut microbiome. Okay, so you can take maybe more fermented food to remain with that good gut microbiome, but otherwise there is nothing to do from this side. But it can be different. As a 31-year-old woman, she is obese with a body mass index of 32, also no type 2 diabetes, and she wants to lose weight for cosmetic reasons. She hasn't really tried, a little bit kind of diet, but not really seriously tried. Okay, so again, in this case, you do a gut microbiome test, and the thing is different. So for her, the microbiome-based obesity risk is far increased, not the highest, but it is increased. A lot of firmicutes, say, LPS bacteria, inflammation, always bad, and low bifidobacteria, which is not good. Okay, and the whole combination. And well, with that, of course, a combination with bifidobacteria, because this is the one thing that is most missing. And actually, these studies that have shown the weight loss reduction effect, they basically have used bifidobacteria lactobacilli. So, and these species were most promising in all the trials, basically. Again, with a dose that is high enough and 12 weeks, and of course, always accompanied by basic measures of weight loss reductions, and this was working very nicely here. Another case which is very, well, I found it very impressive, to be honest, was a 42-year-old patient. So with a body mass index 33. He really wanted to lose weight, and he really tried. And it was, I think he had several diets, and he was very consequent, principally. And he failed. He was not successful, and he was also that he said he even gained a little bit of weight. And it was, of course, very strange because the diets were calorie restriction diets. And the gut microbiome test was very interesting. So he had a very high risk that his gut microbiome would really hinder him from losing weight. Again, a lot of firmicutes, LPS bacteria, low bifidobacteria, low lactobacilli. Okay, and now you say, okay, all the trials have shown bifidobacteria, lactobacilli, that's effective, so let's do it. But careful, the butyrate-producing bacteria were increased. So again, even despite the fact that that he had low lactobacilli and bifidobacteria, do not give these probiotics in this situation, because it will increase the proportion of this bacteria, and this might be a huge problem for him. So that would be counterproductive, very counterproductive. So for him, he has to change the diet more to protein and fat-based diet and not so many carbohydrates. When you ask him, what have you done for a diet? Then he said, well, I made a low-fat diet. It was logical for me. I'm fat. I make a low-fat diet. Yeah? So, sounds principally not unlogical. And for him, it was also more easy because there were so many products in the supermarkets, low-fat products. But what has he done? He has basically replaced the fats by carbohydrates. Exactly what he shouldn't have done. And that's also the reason why he even gained weight. After he has changed the diet in that direction, everything was very fine. He could, with another diet, lose. And the gut microbiome test has basically shown this. Very interesting. Okay, so take-home matches for the second part. I'm coming to an end. You are soon released. So what was the most important things? I think I cannot stress enough how inflammation is the one major driver for aging processes. Okay, so which is called inflammaging, and well, so the deviation basically of the biological age or the chronological age from the biomedical age is very important. If you show that, this is something that can really activate patient. And we do have microbiome biomarker that can show whether the gut microbiome is a gateway of such an inflammation. Just one gateway, but a very important and also a very frequent gateway of inflammation. Well, and again, you can make that visible, and you can personalize the strategies regarding treatment, which is actually not only based on the inflammation part, but also like for cardiovascular diseases, on the part for metabolic processes, yeah, and of course also on the part when it comes to obesity, which is a very, very big driver of aging. Okay, and with that, thank you very much for your attention. Hvala lepa. Thank you very much. And again, if you have questions, happy to answer. I am tired. Yeah.
Did you make some tests to see for anti-aging levels of the inflammation and dysbiosis, or some levels of dysbiosis with the telomeres of sirtuin or some other markers of anti-aging?
Not yet. We have now established a test, so this will be released in the summer, and then we can have a look. And we work with a lot of our doctors together, and they are very keen in using this, and also to somehow monitor the effect of the treatment. And that's exactly the point. You have you don't have principally symptoms, but you have silent inflammation. And you make a test, and it shows you that your biomedical age is not that good, yeah. And you bring it down because of these measures. Yeah, that's the idea.
So, do you consider electromagnetic stress as an environmental factor in dysbiosis?
Wow. the plain answer is no. I mean, as medical doctors and researchers, we always have to consider everything, and it would be very good to see, but I don't know.
We have now epidemic of the many chronic diseases, diabetes,
Yes.
process, everything.
Yes.
And everything started like to go like the mathematically exponential, starting with the non-ionizing electromagnetic radiation.
Yes.
Then we started with the computers, Wi-Fi's, etc.
Would be good to see. I mean, I can imagine. Yes, why not? I mean, bacteria have a lot of sensors, they are probably not immune to any kind of electromagnetic stress. I can imagine. It's just,
I did three projects about the
Okay.
very bad immunity, metabolism, glucose, triglycerides, also you mentioned the cardiovascular risk,
Yes.
the LDL, but what is the ratio HDL and the triglycerides?
Yes.
This is a much bigger risk for cardiovascular disease.
Yes, yeah, absolutely. Well, there are probably some unknown players that still needs to be discovered. we are happy that we can show at least some that we have found.
And one question more.
Yeah.
What is your opinion about how food, especially non-EGA allergic food or intolerance food, have an influence on dysbiosis? And can we treat the hypersensitivity on food or allergic on the food with changing the microbiota?
Okay, let's, we have to dissect the thing. You're talking about the food intolerances that has some immunological affection, like IgG4 antibodies like this. Yes, this is absolutely the case. The reason for it is basically the leaky gut, because the leaky gut brings the food into the intestinal wall, and for some people, not all of them, they react in an immunological way. It's a T-cell reaction, actually. The IgG4 antibodies are just a way to show us. It's a kind of compensation. So the major reason is a leaky gut. A secondary reason is the individual susceptibility to this immune reaction. If it comes together, the only way to get rid of it actually is to treat the leaky gut. This is also what special ambulances in Germany are trying in this case to do. They are specialized on this. And then again, if the leaky gut is caused by the gut microbiome, that would be a way, yes. Then there would be a treatment option, if this would be the case. Yes.
Be a very good option to try to make barriers.
Barrier. If you close it, it doesn't matter if you have, if you still have immunological reaction in the tissue, because it just doesn't come through. No antigen, no reaction. No.
We have one more question.
Yes.
One question.
Yes.
Maybe. Thank you for all. Is there any example or evidence in your experience about using glutamine with probiotics together, and then maybe make stronger our gut patient?
Yeah. Basically, almost everybody is using it together, of whom I know and who is like treating leaky gut. So it makes sense. I think the effect of glutamine alone is there. It is not massive, but it is there. And if you combine it, yeah, it's supposed to be a higher effect. Yes, absolutely okay.
Okay, thank you, Professor Matthias. Svima bi vam se zahvalila na prisustvu. Nadam se da je bilo ovako inspirativno i da stvarno imamo sada da razmenimo neke nove ideje, a mislim da ćemo onda otvoriti vrata za ono što sam rekla na početku, na neku novu saradnju. Mislim da stvarno dobijamo jedan dobar i kvalitetan test. Hvala vam još jednom puno i nadamo se da ćemo se družiti sa nekim novim, jer koliko sam videla 2025. neki novi testovi izlaze, da, koji će biti verovatno interesantni. Napravit ćemo verovatno opet neka predavanja, tako da se nadam da ćemo opet biti ovako u ovom broju. Hvala vam puno još jednom.
Thank you.
You're welcome. Very thank you. I'm absolutely honored for the invitation.
You're tired,
It's really very
probably.
nice.
You're tired now, probably.
It's okay.